Okay, so let's start with the assessment process. What are some of the biggest challenges that practitioners face when they're trying to identify ADHD?
Right. Thank you for that question. I think with just like any other diagnoses, right? Overlapping symptoms with any other comorbid diagnosis is one of the big one, and ADHD also varied symptom presentations, right? So that's another one, and really, I think the one of the bigger challenges I have is by definition, we have to see ADHD symptoms in more than one setting, multiple. So we need the multiple sources of information. So a lot of times when we're just seeing them in one visit, oftentimes we would need, behavior observation or information from school, from their teachers, how they're doing, which is a very important piece of information.
Mhm,
So
mhm.
really getting that, making sure that we have the comprehensive picture of the child, not just from that one 60-minute visit. So that would be the one of the most important, but also one of the biggest challenges I think we as clinicians have, because then that takes a lot of coordination between us, parents,
Right.
and school settings and their therapists. So that's definitely for me personally one of the biggest challenges, but also the one of the most important piece of information that we need.
Anything
I would
you
agree
want to add?
100%. Yeah, 100% with what Dr. Chang said. That is the most difficult the part of making the assessment. It's the overlap with other symptoms. An example, I saw someone yesterday who has ADHD but was also being evaluated for bipolar disorder. And, when we went through the screening criteria for bipolar, a lot of the symptoms were really attributed to her ADHD, it turns out, because, as opposed to bipolar being a lot more episodic with some of the symptoms of ADHD, uh, the symptoms that mimic bipolar within ADHD are episodic, whereas with ADHD, they're present all the time, right? So it's a persistent set of symptoms that doesn't wax and wane. Um, and I think what Dr. Jang said is absolutely right. One of the challenges is getting teachers or school personnel to give us the feedback that we need. Not that they don't want to, but they're busy. So some of the tools that we use, like the Connors form um, or the Basque, can be difficult to get the teacher to fill out. They're busy, and then you oftentimes want them to fill it out more than one time.
I see. So even with those challenges, we are seeing more diagnoses of ADHD than we were, say, a generation ago. So I'm wondering what's going on with what looks like increased prevalence, but probably something else. And even more importantly, who are we still missing?
Yeah, there was a study, actually. It's a timely question. A study just came out, and we'll mention it in our presentation, that the rates of ADHD in the US have actually stabilized. So the data looking at 2017 or 2017 to 2020, I believe, is very similar to the preceding set of data for 3 years prior. So up through 2022, the data looks like the last two sets of 3 year periods have stabilized at around 10.5% within the US. So, and that is in contrast to what, as you said, Rebecca, what we were seeing before, which were dramatic increases with each 3 to 5 year period. So we're finally seeing some stabilization in that diagnosis. Um, don't know why it has gone up as much as it has, and in a lot of studies, the U.S. does tend to lead in terms of the prevalence out of other countries, and I think it is a bit of a still a bit of a puzzle as to why that is. There are lots of factors that have been brought up, um, such as better screening, um, lower threshold to diagnose, um, and oftentimes you know could be that there's just overlapping diagnoses with other disorders such as anxiety, and so sometimes, or learning disabilities. So sometimes one might mistake one particular um, diagnosis, such as a learning disability, for ADHD. And so I think that is, as we're screening more and looking harder, we're finding more. And some of that finding more is probably true ADHD, and some of it may be other diagnoses that we're mistaking.
Okay, I see. And what about the disparities? Are we still seeing groups of people that we are missing diagnostically and who aren't getting maybe the treatment that they need? What are you seeing, Dr. Jang?
I think the disparities may persist, like the similar what Dr. Megerian was saying, due to many factors, including socioeconomic differences, right? But culture perceptions and
Right?
and access to healthcare. But Dr. Megerian and we always talk about how it's complicating matters further. These variables are never in isolation. So it's never just a race issue, never just a socioeconomic issue. It's just kind of everything together for the complicates matters. But we have to definitely look into these barriers because these barriers may make accessing appropriate ADHD interventions more difficult for these groups. But it's never just a one issue; it's all these issues combined that further
Right.
complicate the matter.
And why is it so important that we close those gaps and get better at identifying across all, for example, genders?
Yeah. Again, yeah, we getting more recent research on how we may be missing some of our girls underdiagnosed in girls and women, and but it is very important to be able to accurately identify and diagnose women because their difficulties and struggles need to be heard and be seen, and also diagnosis and means access to proper treatment, right? So it is very important for us to be able to better identify ADHD symptoms in women. And, one of the many things that practitioners can do is to while girls can certainly have both inattention and hyperactivity and impulsivity symptoms, what we're seeing is that they tend to present with more inattentive symptoms. So our girls may not be the ones getting off the chair and just wandering around and eloping from the classroom from what we typically thought of what ADHD might look like, right? So we are seeing that more of the girls are presenting with inattentive symptoms. So that's something we definitely, as clinicians, we need to look for. And even when girls are having more impulsive, and hyperactive symptoms, those behaviors they often look less disruptive than what we see in boys do. So, for example, unlike our boys who have difficulty sitting still, they're just eloping and just you can see that they are disrupting the classroom. But versus when we see the girls, we may see that they're more talkative. And they may interrupt more, but we're not seeing that significant externalizing behaviors. So that might be that they may fly under our radar because we're not seeing those symptoms, overt symptoms. But it is very difficult. It is very important for us to really recognize those struggles because we definitely want to make sure that we help our girls who are having difficulty with their focus and really paying attention.
Thank you. That was a lovely answer. Um, Dr. Megarian, what do you wish more practitioners and professionals knew about diagnosing ADHD?
That's a great question, Rebecca. So there's two ways to answer that question. One is I wish that more primary care physicians had the ability and the confidence and the time, frankly, to make the diagnosis. So when you ask about what I wish that they knew, I think the first part of that answer is I wish the frontline pediatricians had more resources available to them to be able to make these diagnoses because not I would say the vast majority of kids with ADHD don't need to be referred to specialists like our center. Um, Really, we specialize in seeing the kids. We should be specializing in seeing the kids that pediatricians have diagnosed but have failed first-line therapy, so there's a question of whether the diagnosis is accurate, or there's a question of whether there's other co-occurring disorders that might be interfering with the child improving when they are given treatment. And so those are the kids, right, that don't respond to those, first level treatments that we should be seeing instead of seeing the kids that have really never been treated. Um, and I think that's an issue of there's multiple issues there. One is confidence, pediatricians having the confidence to make the diagnosis and feel confident that they did so. Two, it's time and resources. So the time to make this diagnosis, there are great screening tools like the Vanderbilt. Um, but a Vanderbilt is just a screening tool. The diagnosis is made by the clinician. It's a clinical diagnosis, so it has to be made by the psychologist or the physician that's seeing that child. And you can use all these tools, which are great, and they can say, oh, this child meets the criteria, but you have to put it all together, and the clinician has to be the one to say, okay, the child has symptoms of hyperactivity per the parent and per the teacher, but or has symptoms of inattention or impulsivity or lacks focus, but is it impairing them, right? Because if it's not impairing them, it's not ADHD. Because by definition, ADHD is a disorder that is a syndrome that causes a disorder. It causes disruption in the child's ability to perform, to achieve it both academically and socially and functionally. And so when we do these screening tests, it's that clinician piece that puts it all together and says, yes, this child meets all of the criteria for ADHD, and I also see how this is impacting that child's life. I can hear it. And we're kind of missing that because what I just described to you takes time. And a pediatrician's office is very busy. They're seeing sick kids, with upper respiratory infections. They're seeing well child visits, given the time and the tools and the resources to do it. So that's the first problem. Is making sure it gets diagnosed early and properly at the medical home or the psychological. The second problem is that kids do have co-occurring symptoms, and because of the co-occurring symptoms, ADHD, I would say, very often, probably at least half the time, occurs with something else. And so, on top of making sure that you've done the proper screening and treatment for ADHD, you need to also make sure you've screened and asked about other potential diagnoses or problems, such as conduct disorder, oppositional defiant disorder, anxiety disorder. And then it becomes even more complicated. And so, you really need the challenge becomes, again, having the time and the resources available to do the proper screening and then institute the proper treatment. The other challenge that I see, and I think Dr. Jang sees, is that one of the key components of treatment isn't just medication, right? It's parent-based training. And there's not a lot of tools out there. There's not a lot of providers out there. There's not a lot of resources out there for parents to access to be able to get that parent training, especially for the younger kids. And when the kids get older, we really like to talk about executive function coaching or coaching. Again, not a lot of providers out there that do that. So these are where we see the challenges right now.
Well, let's talk for a second about the executive function piece because I noticed that in the webinar you plan to spend some time talking about the development of executive function. And I'm wondering, why is it so important for practitioners to understand those stages?
I'll let Dr. Jang take that one.
Okay.
I'll start with that.
Yeah, understanding different appropriate age appropriate functioning executive functioning is important because so that we know in 2-year-old what are some of the expected development, because that looks different than what when they're 5 and when they're in kindergarten versus when they're in elementary school, because then sometimes we have many wonderful but worried parents coming in with their 2-year-old, like, I think my child has ADHD because he cannot sit still for more than 5 minutes. And we're like, we don't expect them to be sitting down for more than 5 minutes when they're 2. And this is a totally normal, age appropriate development, right? So then each development stage, the level of attention, focus, and executive, we don't expect a 2-year-old. They're like, parents are like, he's always losing things. He can't plan for things, because those are not part of the expected age appropriate executive functioning that we are. It's required or necessary for that age level, right? Age range. So that's why it's important for both parents and clinicians to understand what are age appropriate development across age range, so then we can accurately assess and diagnose ADHD symptoms.
Well, thank you both, Dr. Jang, Dr. Megerian. Thanks for your time. We are so excited about this webinar, and I know it's going to be really beneficial to a lot of clinicians and educators out there. Thank you.
Thank you for having us.
You're welcome.